Hello everyone, welcome to 2-Minute MRCP. Today we'll quickly review gastric cancer. Gastric cancer accounts for around 2% of all cancer diagnoses in the developed world. It is much less common than colorectal cancer and slightly less common than esophageal cancer. Gastric cancer mainly affects older people. Around half of patients are over 75 years old. There is also a male predominance, with a male-to-female ratio of approximately 2:1. The most common type is gastric adenocarcinoma. It arises from the glandular epithelium of the stomach lining. Now, let's look at the risk factors. The most important risk factor is Helicobacter pylori infection. Helicobacter pylori causes chronic inflammation of the gastric mucosa. This can lead to mucosal atrophy, followed by intestinal metaplasia, and then dysplasia, which can eventually progress to gastric cancer. Other risk factors include pernicious anemia and atrophic gastritis. Dietary risk factors include high salt intake, salt-preserved foods, and nitrates. There is also an increased incidence in certain ethnic populations, particularly in Japan and China. Smoking is another risk factor. Interestingly, blood group A is also associated with an increased risk of gastric cancer. Now, let's move on to the clinical features. The typical symptom is vague abdominal pain, usually felt in the epigastrium. It may present as dyspepsia. Other common features include weight loss and anorexia, as well as nausea and vomiting. Dysphagia can occur, particularly when the cancer arises in the proximal stomach. Overt upper gastrointestinal bleeding occurs in only a minority of patients. Gastric cancer can spread through the lymphatic system. A left supraclavicular lymph node enlargement is called Virchow's node. A periumbilical metastatic nodule is called Sister Mary Joseph's node. Now, investigations. The diagnosis is made by esophagogastroduodenoscopy, or OGD, with biopsy. Histology may show signet ring cells. These cells contain a large vacuole of mucin, which displaces the nucleus to one side. A higher number of signet ring cells is associated with a worse prognosis. For staging, a CT scan of the chest, abdomen, and pelvis is indicated in all patients to look for metastatic disease. Other modalities that may be used for staging include endoscopic ultrasound, FDG PET scanning, and preoperative staging laparoscopy. Finally, let's look at management. Surgical treatment depends on the extent and site of the tumor. Surgical options include endoscopic mucosal resection, partial gastrectomy, and total gastrectomy. Chemotherapy is also used in the management of gastric cancer. So, remember the key points. Think of an older man with vague epigastric pain, weight loss, anorexia, and possible dyspepsia. Remember Helicobacter pylori and the progression from inflammation to atrophy, intestinal metaplasia, and dysplasia. Diagnosis is by OGD with biopsy, and staging includes CT of the chest, abdomen, and pelvis. And finally, signet ring cells indicate a poorer prognosis. That's all about gastric cancer. Thanks for watching 2-Minute MRCP. If you found this helpful, don't forget to like, share, and subscribe to 2-Minute MRCP for more quick revision videos.